All right, we're going to continue our discussion of autism and discuss the diagnosing of autism. It's important to understand that with this particular disability, you can have a medical diagnosis of autism and not be eligible for an IEP, or you could have the educational diagnosis of autism, which does make you eligible for special ed services, but not have a medically verified diagnosis of autism. That's unusual for disabilities, to have two criteria that don't necessarily support each other. So we're going to start first with the medical diagnosis of autism. And as I mentioned in class, in the past, we've used what's called the DSM-4. The one that I was probably has been used for a majority of my time in special education. And now we've moved to the DSM-5. But the DSM-4 criteria for autism is different than it is now in the DSM-5. And so you're probably thinking, why are you even talking then about the DSM-4? And the reason I am is because you still may see IEPs written for people, especially if they're in secondary levels, that has the DSM-4 criteria in it. So it's important for you to understand the criteria shift. Personally, I would say that I still feel that the DSM-4 criteria for me was a little bit more accurate and understandable. The DSM-5 has kind of eliminated one of the categories that I think is kind of important to trail with autism. So let's talk about the DSM-4 first. The DSM-4 uses what's called the triad of deficits. So you can see there's three areas that are put together to determine if there's autism. Now, as you remember from earlier this week, I told you that we don't refer to Asperger's, and we don't, the nonverbal learning communication disorder, the nonverbal one would have been more in like this area of the Venn diagram. So that's why because there's not a triad anymore, that's why Asperger's got eliminated, because there's not a place for it. So I'm going to explain to you how this all kind of wove together. So in the triad of deficit, we're going to evaluate, we had evaluated students in their social skills. Social skills meaning like how they interact with others, whereas communication was a separate category. So your not just your language skill, but also the tone of your voice, those kinds of things were put into communication language. And then there was the behavior aspect, and looking at specialized behaviors. And I'm going to go through each of these criteria for you so you understand what we were looking at when we use the triad of deficit. So when we would diagnose a student, medically diagnose a student for autism, it was done all really pretty much with observation. There is no blood test that we use to determine if this child has this condition. So if the child had social deficit and behavior deficit, but they did not have any severe communication issues, they would fall into this little green area, that green and red overlap area, and that was called Asperger's. If the child had social and communication deficits, they were often termed again as something called PDD-NOS, because they weren't truly all three categories and they couldn't fill in the categories. They gave a child that label, and it stands for pervasive developmental disorder not otherwise specified. I would see a lot of PDD-NOS as the diagnosis in a medical evaluation for a child that was fairly young, and that perhaps a doctor didn't really want to call it autism yet. So he said, maybe down the road it's going to turn into a diagnosis of autism, but for now we're just going to call it a pervasive developmental disorder. So that would usually is what would happen in this area. If the child had some behaviors and some communication, again, PDD-NOS. But if the child had all three, social, behavior, and communication, the sweet spot here in the middle, then it was determined that it was autism. So that it was all observational checklist. It still is. And so using this criteria was how we determined what the diagnosis was according to the DSM-5. So let's take a look at what we mean by communication. So in autism, when the communication deficit can range dramatically. It can range from a complete lack of ability to use words, so the child is nonverbal, all the way up to the kind of language that we would call precocious, highly sophisticated. So they sound like little professors. They're very intelligent speaking, but unfortunately they sound that way, but that is not necessarily reflective of their abilities. When we would talk about communication, we also have to talk about the nonverbal aspects of communication, which have gestures and eye gaze in them. And as we look at young children, we would also include in there their babbling. So we're going to take a look at neurotypical eye gaze, vocalization, and gestures, and then what it looks like in a non-neurotypical child that has autism. So in autism, if a child is having issues with their eye gaze, and it would be that they're staring fixed at objects. And remember, I mentioned that because of the way the brains are structured, that children that have autism tend to focus on objects over faces. So staring, they won't fixate on a person's face like a young baby might do, staring lovingly, fixedly at their parent's face. Instead, the child with autism chooses to stare at a living thing, like a toy or something in the room other than a person. They seem to not be aware of the environment around them. In fact, at first, parents might think that the child is having a hearing difficulty or is even deaf because they don't react to things that are going on in the environment around them the way a neurotypical child would react to noises, and they don't respond to their names. And you can see that that's here. They don't associate even mama to mom, but they don't even associate necessarily their name to themselves. And they tend to be very preoccupied with parts of things rather than the whole. A way to think about this is a child with autism is given a Matchbox car to play with. Most kids who are neurotypical, given the same Matchbox car, would probably try to run the car on the floor or on their arm, and as they get older they might even make car noises and play with the car as a whole. Whereas the child with autism is going to be very preoccupied with a part of that toy. A lot of times they'll just take their finger and spin the wheels over and over again, and they don't play with the toy appropriately. So they're not using it like a car, they're just looking at that part that spins. As far as babbling and vocalizations, they don't orient to conversations. So if someone to the right of them says their name or starts talking, a neurotypical child is going to turn and look at that person. A child with autism doesn't generally orient that way. And as I mentioned before, they tend to not react to their name. And that's in a special education early childhood classroom that's focused on children with autism. This is one of the skills they work on first, is to teach the child to connect their name to them and to react to that. A child with autism isn't going to have what we call normal prosody. Prosody is the ability to lift and lower your voice appropriately. When you ask a question, you raise your voice. When you are angry, it tends to have more abruptness to it. That normal babbling that a baby will have replicates the prosody that they're hearing in mom or dad's conversation, even though they're not using words. A child with autism doesn't have that. They tend to, it sounds very robotic, and their babbling has a very different texture to it. Children that have autism also, the nonverbal gesturing is very different. instead of using their finger to point to something, they most often will take the hand of their parent or who's ever caring for them. They'll lift that person's hand to point for themselves. So they use an adult as a tool to point for themselves or to move things around. They don't make that connection that their hand does that. When they replicate things like waving, for example, they replicate waving like most babies. When you say wave bye-bye, they'll turn their hand and wave bye-bye to the person that they're saying goodbye to. A child with autism doesn't see it that way. When they see someone modeling waving bye-bye to them, and think about this, when you wave bye-bye at someone, your palm is facing them, right? And so a child that is replicating bye-bye is going to turn their hand inside so the palm is facing their face, and it's essentially they're waving at themselves. But that's because they're very literal, and they're waving that, making that gesture exactly the way they saw it from the adult doing that. So some terms that we need to have in our vocabulary for developing language skills are the words like motor imitation, joint attention, and object play. And you can see the definitions for those here. So we've already talked about motor imitation, that waving bye-bye is imitating a motor skill. Joint attention is turning to the person who's talking to you and maintaining an eye gaze to that person to draw them into a conversation. I always make this example that when you're having a conversation with someone and you're face-to-face conversation and you notice that their eyes are starting to wander, this is a cue that you have that they're no longer really interested in what you have to say, and it might be time to wrap up the conversation. Children with autism don't read those cues that well, and in fact, eye gaze in general, to maintain a continuous eye contact, direct eye-to-eye contact with another person, causes them pain. It's a painful process for that. So kids with autism will divert their eyes often to the side, and they'll be talking to you but looking to the side or focused on an object but not a face, and that all has to come in with their ability for joint attention. And then object play is when you can take a toy and it represents something in reality. They take a toy phone and they talk on it like it's a real phone, like they saw mom or dad do. They have a dolly and they have a spoon and a bowl, and they pretend to feed the doll because they're doing symbolic play with it. So children with autism have difficulties with that, as you can see in this next slide. So they have difficulty imitating. They create errors because of that. Their joint attention is one of the biggest indicators that we have in little ones that there might be autism happening, because we notice the eye gaze right away. And then object play, as I mentioned. So where we see neurotypically, these are the things we're looking for. This is what we see in kids with autism. In the classroom, you're going to see things like this happening. They are not going to read your nonverbals very well. They're not going to read the nonverbals of peers very well. So they have difficulty understanding nonverbal body language in general. So they are also, obviously, because of the gaze issues that they have a difficulty following and tracking a discussion where people are turning and moving from person to person. And then we have this they are very willing to take unsafe risks. They don't understand, again, that subtlety of a situation to know that perhaps this isn't the best thing to say right now or the best thing to do right now. They just their filters are a little off there. Here are some more. I've talked about a few of these, but here in the middle where you see they may have a more serious look on their face, they tend to be very flat in their emotional status. If you remember, I talked about Andy in my class on the other day. Andy would have the same facial expression for situations that he was describing to me, and he was using the word, "Today was awesome," but his face did not show any kind of joy, and his tone was, today was awesome. It was very flat affect. If I asked him how his day was going, and he would say, today was awful, it came the same way as awesome did. So there was no difference in the way he looked or sounded, but in his heart he was feeling the difference, but he wasn't able to bring that out. And they're conversely, because they don't use tone and facial expressions very well, they also have difficulty reading tone and facial expressions that are used by others. When it comes to speech, in students, especially younger kids at the beginning, we notice that they may have something called echolalia. So I'm going to play this short video where you can see this little boy that is echoing everything that he hears. And we'll talk about it after you've kind of watched the clip a little bit.
Ring, 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 ring. Hayden. Ring, 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 ring. Hello? Hello? How are you today? Yay! What? How's it going? What you doing today?
What's he doing? What we doing?
What are you doing?
What we doing?
So what you notice with this little guy is he's using the same prosody and intonation that the adult is using, and you might say, well, that's what any little kid would do, but a little child that has verbal skills in hand is not just going to repeat what mom says, but they're going to add to what mom says, or they might even take away from what mom says, but they don't necessarily echo it exactly. Echolalia is one of the early indicators of autism. You'll notice that the child just seems to be a little parrot, repeating everything exactly the way it was said, without any, and sometimes incorrectly, repeating something that they heard said, and it's not appropriate or the right time for them to be repeating that. So you can tell that there's no cognitive understanding of what's being said by the adult, because they're repeating it at a time that doesn't make sense. There's also the kind of speech that we call pedantic speech, and that's the kind of speech where they sound like an expert on the topic, and they might belie that they are very intelligent and therefore know a lot about this topic and should be a worthy source. But the truth is they really don't necessarily have the understanding that their words are. So we'll listen a little bit to this young lady who admits in the beginning of the video she has autism, and then kind of relates that. I'm hoping we can get that. Oh, there we go.
Hello, I hope everyone had a good Easter. I already did this video, then I had to delete it because I had my phone the wrong way around, so that when I was recording it, when I uploaded it, it looked really weird and there were like black down the side. So I decided to just scrap it and come back to it and say exactly the same information, but I feel like I'm going to chop it a bit because it was like 20 minutes last time, so I'm going to try and get it under 10. So sorry if it's a bit not so in depth, but I'm trying to go quickly because I feel like it's a bit boring if it's more than 10 minutes long. So I want to talk about the Asperger's voice because I feel like people on the autistic spectrum have a very specific way of speaking, and it's one of the ways I can almost immediately tell if someone has Asperger's. Obviously.
Okay, and she's referring to Asperger's because remember that kids that were identified with Asperger's, their IQ was normal to above average. That was the same variety as you would have, but their communication skills were very high. So she sounds a little authoritative, but they also go on and on and on about things that aren't relevant to the conversation, and it's difficult to interrupt a person that is on a pedantic rant like this. You might try to insert something and they really don't let you kind of insert yourself into the conversation. Let's talk a little bit about the socialization aspects of Asperger's. And I'm going to use this example here for something that you can kind of see.
Morning. Morning. I have to say, I slept splendidly. Granted, not long, but just deeply and well. I'm not surprised. A well-known folk cure for insomnia is to break into your neighbor's apartment and clean. Sarcasm? You think? Granted, my methods may have been somewhat unorthodox, but I think the end result will be a measurable enhancement of Penny's quality of life. You know what? You convinced me. Maybe tonight we should sneak in and shampoo her carpet. You don't think that crosses a line? Yes! For God's sake, Sheldon, do I have to hold up a sarcasm sign every time I open my mouth? You have a sarcasm sign? No, I do not have a sarcasm sign. You want some cereal? I feel so good today, I'm going to choose from the low-fiber end of the shelf. Hello, Honey Puffs.
Son of a bitch!
Penny's up.
You sick, geeky bastards!
I
How did
apologize
she know
for
it
the
was
language.
us? I may have left a suggested organizational schematic for her bedroom closet.
Leonard!
God, this is going to be bad. Goodbye, Honey Puffs. Hello, Big Brand.
You came into my apartment last night while I was sleeping?
Yes, but only to clean. Really more to organize. You're not actually dirty, per se.
Give me back my key.
I'm very, very sorry.
Do you understand how creepy this is?
Oh, yes, we discussed it at length last night.
In my apartment while I was sleeping.
And snoring. And that's probably just a sinus infection. But it could be sleep apnea. You might want to see an otolaryngologist. The throat doctor.
And what kind of doctor removes shoes from asses?
Depending on the depth, that's either a proctologist or a general surgeon.
Okay, sorry about the language. I couldn't find a clean clip of that. But what we're demonstrating here is the socialization issues that people with autism have. They don't read that someone is upset. They don't understand when someone is happy. They really struggle with jokes and sarcasm because they're very literal. So as you saw when Penny mentioned the shoe thing, he went to the extreme of, well, if it was this, then we'd have to have this kind of doctor. Whereas most people would understand that is sarcasm. In the secondary level, well, even in middle level, but teaching children exactly what sarcasm is and cues that you can pick up on when somebody is being sarcastic or telling a joke, those are things that we have to teach in social skills classes for kids on the spectrum. When it comes to interests and activities, these children tend to have what we call perseverations, where the interest is above and beyond. You know, there are people that have interests in certain things in life and they tend to maybe talk about them more. This is even beyond that, where I chose this picture because the high school student that I had, still as a 16-year-old was fascinated with anything to do with Thomas the Tank and trains and those kinds of things. So he would talk for hours about trains. And beyond and above what maybe somebody who is truly just a hobbyist might have in there. I should go back to activities. They also tend to look very OCD in some of their behaviors, and I'll show you a video of that in a little bit. So I want to bring you back to, this is the triad of deficit. So we talked a little bit about the communication and the behaviors and the social skills. So now when the medical community decided to update the DSM, their diagnosis manual, they went to the 5th version and they changed their criteria for autism. So the new, that's a little stretchy here. The new criteria is two things, not 3. They dropped behavior and they put in there strictly communication and social. So they look at the communication aspects and the social aspects. They do not bring in the behaviors. And that's where I thought, I'm not sure what the thinking was on the medical community side of leaving those behaviors out. Perhaps it was because, as I said, not everybody necessarily has a behavior preservation, these extreme interests or activities, repetitive activities that get them on the radar of this is like over the top. It might be slightly on the edge, but it's not enough to say it's really socially inappropriate. And they still would have autism. So perhaps that's one of the reasons that they brought that in. Others would say that behavior aspect absorbs into the social deficit aspect of it. So now when medical professionals evaluate for autism, they just look at these 2 categories instead of the 3. So some things that you might be able to utilize when you are looking for the difference between a child with autism or without autism. There's 2 things that you can look at. First, I'm going to take you to the CDC, and this presentation is linked again in Moodle for you, so you can hyperlink to there. But one of the things I had you do in Ed Psych, and if you've taken Ed Psych, this sounds familiar to you. If you haven't yet, it will be something that you do, is I had you create what's called developmental milestones for your grade level. What the CDC has are different things that are appropriate for children at certain developmental phases in the early years, from the 2 to 5 years, where we start to see autism. You can even download on your phone as a parent a milestone tracker, and you could be marking things. This is all very helpful information that you provide to the pediatrician when you're bringing in your child and you're thinking that there's something not quite there, having these things to share with them. And then there's the milestones in action pictures and videos of these children that are appropriately doing things at the age that we're talking about here. So you can see videos and pictures of a 4-month-old or 2-month-old, and so they give the parents a lot of resources to because parents are going to be the people that are probably going to first notice things that might be slightly off. The next thing that I like to use, and I'm going to have to jump out, and I'm going to pause the video here, and when I come back I'll have the website up for you because it takes a little bit to find the link. So I'm going to do that, and I'll be right back. Okay, I found the site, and it's like I say, they've kind of hidden it, so sometimes when I go for it I can't find it right away, so that's why I paused it. But I'm always, when I Google search for this, I always type in the Autism Speaks video glossary, and by putting that in, it links you to different clips and things, and the video library is right here, and you can see what the video library does is that it has in it clips of neurotypical development and red flag development. And let's see if we can get this to open. And see if we can see some videos that will work by that. And this is where sometimes it has difficulty.
We're very excited to release About Autism in Toddlers. It will be free to the public. It will have video illustrations of at least a dozen or more toddlers with autism, most of them around 18 to 20 months of age, to really show what this looks like. It will have the side-by-side video players to show the early signs of autism next to a child who's typically developing. It will also show some of our families who participated in our early intervention study, and it will show their children what we call at baseline, at the beginning of the study, and then it will show their children after a year or two of the family working with them, how far their child has come.
It was very time-consuming and big commitment, but it was totally worth it. I mean, I look at our son now, and I see him in first grade, fully integrated classroom.
Science and math are things he's really into. And
Okay, so where this little video clip was coming in, and particularly what I was interested in and it was a lot easier to find, but now you can find it on the Navigator. So you have to go to that site that I showed you and then to the Autism Navigator, and the videos that are there. What I particularly like, I'm trying to find that still shot of it here, is where they this kind of thing where they showed a child that's typically developing and a child that is just demonstrating signs of autism, because this is really helpful for parents to go, is what I'm seeing normal? What they have lots of questions, and it's helpful too because sometimes it allows the parent a chance to absorb and maybe come to terms with what might be going on without having someone to have to like physically point it out to them, because they can see it through these comparison videos. So I've used this a lot. I wish honestly that Autism Speaks wouldn't have hid them, so it makes it kind of difficult to find them. But for example, what's the difference between Charlie and Luke is that Charlie is in the video when the teacher blows the bubbles here, he reaches up and he's trying to catch them. He's interacting with her. When he wants more bubbles, he grabs her hand and then she blows them. Whereas Luke doesn't pay any attention to the bubbles or the person. He's fixated on the cover that's on the bottle. And that is a typical sign of not interacting correctly with objects around them. So that's something that you might note as a resource for parents that you're working with them, as you're working with them. I'm going to finish up this section really quickly here by talking about diagnosis versus eligibility. So diagnosis is given by a doctor. That's a medical thing. So a child goes through and the assessment with a doctor, a pediatrician, and according to the criteria in the DSM-5, meets the criteria for autism. However, that doesn't mean that that child necessarily meets the criteria for the state of Minnesota. Or any other state that they might be in. So I'm going to show you the criteria, and then when we have a class, I will give you a printout of that criteria. Okay, so here's the criteria checklist for ASD, and with ASD, because it's an observational type of diagnosis, there's multiple sections to the criteria report. So the first section, Part A, says that the team must document that the student demonstrates patterns of behavior as described of at least 2 of the 3 sub-items. So the sub-items are 1, 2, 3. So these are the 3 areas that you have to look at. And you'll notice that the educational diagnosis has still continued to include the behavior, even though the medical diagnosis no longer brings that in. And when you get this checklist in hard copy, you'll be able to take a little bit more, a deeper dive into those 3 categories. But we're talking about impaired social interactions, or impaired communication, or repetitive stereotypic behaviors. So all 3 of these are looked at and interpreted. So this is built off that triad of deficit. Then we move to Part B. And the report must include documentation for data in all 4 of these areas. They have to have their present level of functioning. They need to have education needs identified, the observations of them in 2 different settings, and a summary of their developmental history. So just like DCD, where I told you that the criteria didn't necessarily need assessments, like a cognitive or achievement assessment. For ASD, the checklist does not include necessarily a cognitive and a achievement assessment. Now it could, but the criteria doesn't look for that. So this is going through this checklist. If during the assessment of this child, we go through Part A and we go through Part B, and they meet the criteria as it's described, then that child is either checked yes or no, that they are eligible for ASD. So that's the educational diagnosis of ASD. I showed you the Minnesota educational criteria. The criteria for each state can be slightly different, but not necessarily all that different. You're going to obviously, because autism is has those consistent categories, their criteria isn't going to look super different than Minnesota's. Okay. What should be included in an assessment as we're looking at assessing a child in educational assessment? So as you said, the development has to be in there and the observations, but we also are going to include parent interviews, and then we're going to do a functional assessment of these different things. There's social behavior, their communication, and then the adaptive behavior that we talked about before. But also some things included generally are their sensory. So we do a sensory checklist on the child. We might look at their emotional, so school psychologists may come in because we usually have issues with comorbid conditions, sometimes depression, or there might actually be some pre-schizophrenia or some sort of mental health issue that might be coming in, and then cognitive. So it's still there even though it's not on the criteria. We may put that in an assessment report. Different tools. I'm going to just show you a couple because you can Google any of these and probably pull up the checklist, because autism is diagnosed through checklists. It's not necessarily it's not a normed test. So I'm going to show you first the autism behavior checklist, which is usually used for older kids. And I'm just going to show you briefly a couple of the elements on the checklist. So as we look here, remember we talked about spinning and twirling, so whirls self for long periods of time, learns a simple task. So if the parent or the examiner checks these things, then there's a score level given to those things. And then when we add up the score on the checklist, the overall total, then becomes, if it's yes, you check here, you add a 4. If it's not, it's a 0. So this is one of the checklists that's used for older kids. Then a checklist that would be used for younger ones, for toddlers, is called the MCHAT. And we'll take a look at some of the pieces of the MCHAT. Now, this one in particular that I pulled up here is a instant scoring MCHAT online, and you can get results in a limited report for free. So a parent or a teacher could fill this out on a younger child that's in their early childhood center, and it would give you some feedback, not the full report. Obviously, as a registered user, you have to pay for this, but here's some of the scores. If you point at something across the room, does your child look at it? That's evaluating joint attention. Have you ever wondered if your child might be deaf? Remember, I told you that lots of times we think the child has a hearing problem and they're simply not engaging. So these are some of the questions that help the parent determine, or the teacher for that matter, determine if the child is on the spectrum. So it's a start. But what I want to emphasize here is look at all of these. These are observation scales. So it's an observation-based assessment. All right, so let's talk it out. Okay, the child has now been assessed and has received the diagnosis of ASD. So how do we help them? Because bottom line, that's really what you want to know. How do you help this child in your classroom? So we're going to talk about behavior and social competence first. So we need to understand that what is the purpose of any behavior in your classroom. And we need to always understand that. What is the purpose of this child's acting out, or what's the purpose of this child's behaving in a certain way? Behavior is communication. Sometimes the behavior is the brain's way of trying to be alert or stay balanced. That's what we talked about with the stimming. Sometimes the behavior is related to the context, what's happened before or what happens after. And sometimes you just have to face the fact that a behavior, especially in a child with ASD, is repetitive for the sake of being repetitive. So behavior is also driven by your needs. So we can determine, based on looking at the analysis of the behavior, is it attention seeking? Is it reward seeking, getting something tangible? Or is the behavior to escape? And those are generally behaviors, needs that come with behaviors in any child. And then with the kids on autism, we might add this fourth category, is the behavior of stimulation behavior. Is it trying to wake up my brain so that I can engage in something in the classroom? So when we do an ABC analysis of a child's behavior, we look at 3 things. That's what the A, the B, and the C stand for. We look at the antecedent. Where is it happening? When is it happening? And who is present? And we look at those things because maybe the room environment, maybe there's a smell, maybe there's an issue with lighting that is causing the behavior. Or when, maybe this is happening right before lunch and the child is hungry. Maybe it's happening after lunch when the child is sleepy. Let's face it, sometimes the behavior is precipitated by another person, by another adult or child in the room. So we look at those ABCs. So when I start with an ABC analysis, however, I start with the B. I describe the behavior. And then I look backwards and I try to say what happened before the behavior that I saw, and then I look at what happened after. So when I look at the behavior, you describe the behavior. Be objective. Be so clear that another person might be able to actually imitate the behavior that you're describing, just simply based on what you wrote down. There should be no emotion attached to behavior. So if I had an incident where a student hit another student, I wouldn't say Stevie was violent with Karen. I would say Stevie hit Karen. Put no emotional attachment to what I'm describing. And then I might look at, okay, what was happening in the classroom before that happened? Here's the behavior. And then what happened afterwards? Because sometimes the consequences could actually be causing the behavior. Because if that child, if we go back to here, is trying to get attention and the consequence of their behavior was they got attention, then we need to change the consequence. If the consequence of the behavior was that they got out of the room and that was what they were after, then we have to change that consequence so that that behavior stops. So it's very important to be taking a thorough look at an ABC analysis. We're going to do some more ABC analysis later on in the semester. But as we take a look at these, we do look for patterns. So we're not going to just observe a behavior once. We're going to look at this behavior and try to observe what's going on before it and after it several times. And then I have some ideas here for looking for different things that as we might reflect on it. Okay, I've already talked about this, so I'm not going to spend a ton of time, but remember the story that I told you about Andy, and it said fire and pull down, and he focused on the pull down. The connection to, it doesn't say here in case of fire even, it just says pull down. So that's where we needed to generalize, you don't pull down unless there's a fire. We had to really work on that. Generalization is applying what you've learned in one situation to other similar situations that we've learned. This is a really cool tool that I use with my kids, not just on the spectrum, but in general. We would have, it's called the Incredible 5-Point Scale. And what the main thing of the scale are these 5 numbers. What's a 1, what's a 2, what's a 3, what's a 4, and what's a 5. So if I were to be working on, as a class, what is the noise level in my classroom? I might say right now we're at a 3, boys and girls, and we need to be at a 1. Or I might say we're actually using our outside voices, we're at a 4, but we need to be at a 2. And so I can use this scale to help children tangibly understand what behavior we're targeting. Now kids with ASD, we could turn that 5-point scale into their emotions. So a 1 is feeling great and a 5 is like, I got to have some support. I need to maybe get out of the room. And because kids on the spectrum have a hard time physically using their voice and their face to demonstrate their emotions, having this 5-point scale where they learn to be able to communicate with you, I'm at a 3, Mrs. Pfeiffer, can you help me with my problem? Or I'm at a 5, I need, Mrs. Pfeiffer, I need to go to my safe room. I need to leave the classroom and go somewhere where I can regroup. So that might be going to see this teacher. So the application of the Incredible 5-Point Scale, this would be something that you definitely would want to put into your strategies chart that you're making for each disability category, and I would definitely put this in with autism because this gives these kids a tangible way to identify different things. And you can find all different ways to apply that 5-point scale. Another way that we can help children with social stories is with their explaining activities or learning behaviors is through what's called social stories. Social stories were developed by a woman named Carol Gray. At least she would say she developed them. I think that social stories were being used before Carol Gray. She maybe put some rubricness to it, some structure to it. And this hyperlink that's on these slides is a video that has Carol Gray talking about social stories. But essentially what a social story is a very where you use descriptive sentences to describe a situation. And in that story, there's directive sentences that describe the expected behavior. So here's what happened, here's what should have happened, and it gives the perspective, possibly, of another person, but most importantly, the story is about the student. So you use the student's name in a social story. So I'm going to show you a social story that is that would be used for a situation. So and this one is using the pronoun I because it's this student's particular social story book. I think it's more powerful, honestly, to use the student's name in the story. And these are simple drawings. What I liked when I would create social stories is I might actually use pictures of the student instead of these graphics. But here's a social story where we're trying to teach them about appropriate personal space with others. So let's just take a quick look at it. When I talk to other people, sometimes I stand too close. We're describing the situation. Here's what we want to have happen. I need to remember to step back and leave some space. Here's the why. Here's the perspective taking. People don't like it when I stand too close. It's not polite to stand too close. It's polite, however, to respect others' personal space. I leave an arm's length between people when we talk. So it's giving them a strategy and a tool, and then the concluding sentence. So when a child needs work on or needs to be reminded that they've made an error in personal space, or they need to practice what personal space means, they read this story. So those are social stories. A comic strip conversation I think is very similar to a social story, but it definitely has a more comic-y pace to it. So here's an example of a comic strip, and in there you use lots of I statements. So you haven't brought my roller skates back. Oh, they're in my room. And you can see here that this person who's the person with autism, and it might be again a picture of that person, he's not reading that Roger's angry. So we have to interpret the emotions here. And so this person is saying, I feel really angry when you borrow something and don't bring them back. And then the story goes on this way. So sometimes instead of a social story, we might turn it into a comic strip story. But the purpose is to correct a behavior through a storytelling. I love social autopsies. I used this a lot. First of all, because kids love anything that kind of is CSI-ish. And so when we use the word autopsy, we're kind of taking apart what happened and then coming back with, here's the mistake I made, and then how can I fix it? And the reason I like social autopsies also is that the child explains what happened, and they may not even understand what they did or what contributed to they come and say, Steve is really mad at me. So what we do then is we sit down and we do an autopsy on the situation to try to figure out what you did to make Steve angry. So I'm going to just show you an autopsy. Oh, the link is invalid. Hang on a second and I'll get you. All right, so here's an example. So in the first part of the autopsy, you are the recorder. And sometimes if the child is older and has good written skills, I might make them write down what happened, okay? So either they dictate to me what happened or they write down what happened, and you try to just put the facts down. Then we go back, and as we've talked through what happened, we look for the social error and who was hurt by the social error. And then we go to, okay, what should I do first of all to correct the error with this person who was hurt? And then in the future, what should I avoid doing? And so this actually was developed by Rick Lavoie, the guy who did the Fat City video that you watched, and is very straightforward and just kind of breaks down the event. This works really well, and I would keep these social autopsies in the students folder so that if something happened again, we could say, this is a lot as we talked about the situation, it's exactly what you did last time. So here is something that we maybe need to work on. So that's the example of a social autopsy. Again, another good strategy that you might want to put in your strategy checklist. A social T-chart, it's kind of a very quick thing. I would use this from time to time. Making a list of things that, this one's a good example of a social T-chart where you go, here are things that are not okay to say, here are things that are okay to say, and we try to set them up as instead of saying shut up, you say what's up. Instead of to say you're stupid, you might say one of these other things. So these are not okay things to say, and these are okay things to say. And it helps for students to actually look through and do this, because you know that sometimes kids will say like, shut up, and they think that it's just kind of said in a lighthearted way, whereas when a child on autism might misuse that phrase, shut up, inappropriately, it could create a real social problem for them. I want to talk a little bit about a term you're going to hear about with kids with, not just kids with autism in general, what's called the hidden curriculum at school. A hidden curriculum are things that are part of school, stuff that you say everybody knows, but we don't teach it. So everybody knows it, but we don't teach it. Well, I will tell you that not everybody knows these things. These are not things that kids with autism are going to pick up, because they don't pick up those subtle social cues very well. So things like, how do you behave in a locker room when you're getting dressed for PE? Those kinds of things, everybody should know how to behave. Not everybody does. In fact, even in the bathrooms and restrooms, kids on the spectrum can especially get in trouble for staring inappropriately in the restroom. Staring's kind of part of their disorder, but when you stare at someone in the bathroom, it takes on a whole different connotation. So we have to work on those behaviors. How we behave at recess and PE. How do you behave in the hallways? I see other people shoving into each other. Is that cool? That's what we do? And then the kid on autism thinks that's what he does, and he shoves his friend inappropriately and hurts them. Lunchroom is a huge problem for kids on the spectrum, simply because the lunchroom is such a social setting, as well as it's so full of stimulation. It's full of smells and sounds and light. So these are all things that, even though you think everyone should know and they should pick up on, you're going to find yourself having to teach kids, not just with autism, but with learning disabilities as well. You need to teach them the appropriate social behaviors. Visual schedules are something that we need to teach, use to teach kids to, because kids on the spectrum are so literal. They are going to need to have a step-by-step, this is the process that we are going to follow with our procedures for this particular event. So visual schedules are at the lower levels very simple. Today, first you do this, and when it's done, you move it to this schedule. And usually we do a visual schedule for each child. So you can see over on the right side where this girl is taking off, her name is at the top. She's taking off each of the things as she does them and putting them into the pocket. A visual schedule that I can show you here, and I'm not going to show you all of it.
Create one later, we can do that. So I'm going to click work then. Now, this is a first then, which is a very good behavioural technique to help manage behaviour. So a child has to do their least preferred activity before they do their preferred activity. So in this case, this student was having to do some writing within his Proloquo to Go communication set. So we ticked that off when he did it. And then he got to choose a reward. But what happens when I click on choose a reward, and you could do this at the beginning or at the end so that they know what they're working for, you can see that for his free time, he can either have some M&Ms, play Mr. Potato Head, watch TV, or use the computer. So Potato Head, that's now put on the board.
Stop the
so we reset it
here. And so you can see that it's just a way to use a tablet to help the child self-regulate the visual schedule. And I see this used a lot. I know that I saw at Washington, they use this for children for behavior modification quite a bit. So it's definitely used, and you can pre-program it so it works really well. Okay, I'm going to finish up with augmentative and alternative communication, because I can tell that my presentation is almost getting to be an hour, and I think that's long enough for anybody to have to listen to me. Hopefully you've been breaking it up with a cup of coffee here and there. And we will pick up the rest of the autism presentation next week in class, because we're still not at my end of the presentation, 100 slides, and I don't want to overwhelm you with all the information that I'm giving you. So I can finish up though with the augmentative and alternative communication, because as we know, sometimes kids with autism have weak communication skills, and they're going to need a way, when we augment, we're adding something to their tool bag of communication skills so that they're able to grow, or we might have to give them an alternative way to communicate. So let's take a look at first an augmenting way. An augmenting way is the PECS system, and I see PECS used in preschool, kindergarten, and even some first grade classrooms. It's a picture exchange communication system, so it's using pictures to communicate, and as the child transitions through the 6 phases, they go from strictly using pictures to using pictures and phrases and words. And so I'm going to just walk you through a little bit of what PECS looks like. So in phase 1, they're using pictures to request an activity or an item. Then in phase 2, there's a distance between the communication book and the student having to go get the activity. By phase 3, there's more pictures, so we start to become a little more discriminating. So instead of just putting a cookie, let's just use cookie as an example. In phase 1, they put the cookie on their PECS notebook, and it's usually like a board, or it's a binder that has Velcro on it. They stick the picture on there. They know that they're asking for a cookie. They will then get a cookie. Whereas by the time we get into phases 3, and especially by phase 6, you can see that they're starting to use sentences. And the key with the PECS system isn't just that they put the sentence strip, I want a cookie, on their PECS board, but they are learning to also say it and point to each word as they say it. So we're moving them from pictures to oral communication. And so a PECS system is used early on in the system. Here are some examples of what PECS can look like. So you can see here are some pictures, and then the child is putting them in. You can use an iPad to create PECS, which honestly is a great time saver for teachers, because in the classrooms that where I saw PECS being used, each of these pictures had to be cut out and laminated so that kids could come in and use them. Whereas using the iPad simply makes it simple for them to put it together using touching the screen. All right. Yep, we're going to stop there with this, and I'm going to move into this section about what you can do if your child is understimulated or overstimulated. Excuse me. We'll start with that next class period. All right. We'll see you then next week.